Hello, everyone, and welcome to today's Adult AML Chapter event brought to you by the HealthTree Community for AML program. My name is Katie Braswell, and I'm the HealthTree for AML Community Director. I'm very grateful to have each of you here for our meeting today and for your support in building this adult AML community. I'd like to let you know that today's session will be recorded, and the recording, along with the slides and any resources we discuss today, will be sent via email to all registrants within 48 hours after the event has concluded. I'll start with a brief Zoom meeting tutorial for those of you who are new to using the platform. We would love for you all to turn on and keep your cameras on if you feel comfortable. Doing so helps us to create a stronger sense of community. You can see on the slide how to turn on your camera. At the bottom of your screen, you should see the microphone and camera buttons. You can click the video icon that says Start Video in order to turn your camera on. With that being said, if you're not comfortable being recorded, you are not required to keep your camera on. Your microphone should currently be off and will be kept off by our team throughout the presentation. During the group discussion, you're welcome to unmute yourself once you're called upon. If you have any questions or comments for us or for our speaker throughout her presentation, please click the chat icon and type them in the chat box. If you're using a mobile device or tablet, click the three-dot icon that says More and then Chat in order to access the chat box. And lastly, if you prefer to verbally ask a question or make a comment directly to our speaker during the discussion time at the end, we encourage you to do so. If you're using a laptop or desktop, click Reactions near the bottom of your screen and then click Raise Hand. If you're using a mobile device or tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. And now let's get started with today's event. First, I'd like to thank our sponsors without whom this event would not be possible: Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. The topic of our event today is titled AML Survivorship, Challenges and Opportunities. Here's the agenda for today. I will introduce our speaker, Dr. Khera, and she will spend the next 30 minutes or so giving us her presentation. After the presentation, we will open it up for your questions and comments and end the event with a few announcements. Let me take a second to introduce our speaker, Dr. Nandita Khera. Dr. Khera is a hematologist, oncologist, and associate professor of medicine at the Mayo Clinic in Arizona. The goal of Dr. Khera's research is to better inform and prepare patients for the psychosocial and financial consequences of treatment, irrespective of their socio-demographic profile. Dr. Khera does a ton of important research for AML patients and their caregivers, especially in the realm of stem cell transplant. So I know we're all in for an extremely informative discussion today. And so with that, Dr. Khera, I'll let you go ahead and get started.
Thank you so much, Katie, for that introduction and for the opportunity to be here today. I am honored to present to you all on the survivorship for AML. Let me see if I can share my screen. All right. Okay, I hope everyone can see the slides. All right, so I just will start by saying that I do some consulting for Insight. So I want to start by going over a few of the patient cases. They're actually my patients that I have taken care of, or I still am taking care of. And they just highlight the spectrum of survivorship or the trajectory of AML diagnosis and treatment for our patients. So the first patient is a 47-year-old non-Hispanic white male. He is a 4-year survivor from a C antigen mismatched, unrelated donor, peripheral blood stem cell transplant for FLT3 positive AML. He has chronic GVHD of the skin. So chronic GVHD is a very well-known complication of stem cell transplant. It can affect basically any organ of the body. And the type that he has causes his skin to be tight, and it almost feels like wood beneath the skin because of the scarring. So I tried to show you a picture here. It's easier to feel rather than to see, but basically what you get is just extreme tightening of the skin, and their joints, the patients that get it, their joints start to feel tight too, and their movements can get limited. He is currently on treatment with prednisone, which is the mainstay of treatment for chronic GVHD, an immunosuppressive medicine called sirolimus, and belumosudil, which is a newer medicine that was just approved by the FDA for chronic GVHD. Unfortunately, he's had multiple complications from the transplant and from all the other things that he is on. He has chronic non-healing ulcer of his left shin, which is again with the scarring process. These patients don't get enough blood supply to certain areas and can develop wounds that will not heal. He has had clot in his left lower extremity. He has chronic kidney problems because of all the medications he's been on. And he had a left fracture of his hip bone due to osteoporosis, which again is a known transplant complication. And then after he got surgery to fix that, he ended up with a bad mycobacterial infection of that hip joint. In addition to the medical issues, he's had a lot of psychosocial problems as well. He got divorced after a year of transplant because his wife felt she couldn't take care of him. He lost his job 3 years after the transplant because of having to take a lot of time off from work to get medical care. And so, not surprisingly, he's very depressed and, in fact, was hospitalized recently for expressing suicidal intent. Our second patient is a happier story. This is a 31-year-old Asian female. She is 3 years out from her haploidentical stem cell transplant. So haploidentical is a half-match transplant. Usually it is from parents, kids, or sometimes siblings. And so she got her transplant from her mother, and this was for acute myeloid leukemia in second remission, second clinical remission. She did have some post-transplant complications, including mild graft versus host disease. And then she had some heart problems, which were more so the result of all the chemotherapy that she had gotten. However, she's doing actually very well now. She's off immunosuppression. She is still on some medication for her heart, but uh, really living a close to normal life. She's back in college pursuing her degree that had been interrupted because of her diagnoses. My third patient is an older male who had MDS, which is, some of you may know, is sort of a prequel sometimes to acute myeloid leukemia or a full-blown blood cancer. And so this patient, he had MDS that has transformed to AML. When he came to me, he had multiple other medical issues, including heart failure, chronic kidney disease, and chronic obstructive lung disease. In addition, again, there's psychosocial aspects to that. He lives with his elderly wife, who has her own set of medical problems. They really have no major system of support in terms of helping them out with their daily activities, including sometimes meals, etc. Um, he After a long discussion, we ended up treating him with 1 cycle of decitabine, which is sort of a gentle chemo that we sometimes use for our older patients that cannot tolerate the high doses of induction type of chemotherapy. But even after that gentle chemo 1 cycle, he ended up having multiple hospitalizations for complications related either to his leukemia or to like infections or to his heart. And so after, again, a lot of discussion, we decided that chemo is probably not the best course for him, that we need to focus more on quality of life. And so he's sort of on a palliative route where he's getting transfusions as needed. We are trying to manage his symptoms as best as possible and keep him comfortable. So hopefully this gave you a sort of a view of what the different trajectories can look like. Just to go over a little bit about the epidemiology of acute myeloid leukemia, it's not a very common cancer. It's if you compare it to like breast cancer or prostate or lung cancer, the number of cases per 100,000 people are not that high. However, we know that it is a very hard to treat cancer, meaning that even after years, the overall survival with this cancer remains extremely poor and that we need to continue to work on improving it. And so for us, hematologists, blood cancer specialists, it's obviously a problem that we really, really want to work very hard to get rid of. So just at a glance, in 2019, there were about 21,000 new cases, which was only about 1.2% of all cancers that were diagnosed in that year. It is usually seen in our older patients. So the median age at diagnosis is about 68 years, although it can be seen in even as young as infants as well. The estimated deaths were almost half of what the diagnosed number was, about 10,000. And so that's where I mentioned the survival over 5 years is relatively poor as compared to some of the other cancers at about 28%. The good news, though, is that things are getting better. This is data from a Swedish Swedish population registry that showed that when they looked at patients who were diagnosed with and treated for leukemia in 2000 to 2004, the second group was 2005 to 2009, and the third group was 2010 to 2014. And this was for patients who are less than 60 years of age. So for them, there was definitely an improvement in overall survival, a decrease in overall relapse rate, and an improvement in what we call treatment-related or non-relapse mortality. When they looked at this data for our older patients above 60 years of age, there was improvement, but it was not quite as significant as it was for our younger patients. The other good news is that this was 2014. So since 2014, our landscape for treatment for leukemia has changed enormously. We have now a lot of new agents that have been approved that have made it possible for us to even treat our older patients for their leukemia and improve their survival, improve their life expectancy. So this is just a snapshot of, it used to be when somebody got diagnosed with AML, they either used to get the high dose chemotherapy called 7+3, called induction chemotherapy, or they used to get a gentler chemotherapy, or if we didn't have anything that we felt we could offer them, they would go on what we would say supportive care. However, now we have all these testings, very sophisticated tests that can tell us about the various mutations in the AML, and based on those, some of those mutations, there are treatments that can target those mutations. And so a lot of times these people, whether they are eligible for or ineligible for intensive chemotherapy, they will have options to be on treatment sort of tailored to their level of functional status and their mutations and so forth. And I'm not kidding. The good news is that right now you see it all fit in one slide. The hope is that over the next couple years, if things continue to move at the same pace, this would not be able to even fit on a slide based on the explosive advancements that we've been able to make in the world of AML. And hopefully those curves that I showed you in the previous slide will look much, much different, and we will see marked improvement in survival for our AML patients. All right, so moving on to the survivorship piece. So this is from one of the, Ned Adler. He's a big name in survivorship literature, and this is kind of the diagram they came up for what is survivorship care. And so it used to be thought that somebody got diagnosed with cancer. In this case, since we are talking about AML, so they would have a diagnosis of AML. They could get treatment with an intent to cure, and they could either become free from AML, they could have a disease that sort of goes on and turns into more of a long-term chronic disease, or they would not respond to treatment and then would need more of a palliative treatment, which is again for some patients, especially our older patients, our frailer patients, this may be the first course as well. And eventually we know that they could develop a second cancer, or they could relapse with leukemia and sort of go the same path again. And it used to be this gray box was considered survivorship care or survivorship phase. However, the latest thoughts from the National Coalition for Cancer Survivorship is that this gray box actually starts right here at the time of diagnosis and staging. And so anytime somebody is diagnosed with a cancer, in our case with an acute myeloid leukemia, that's when they become survivors. And it's not just the patient, it's also their caregivers that are now included in the definition for cancer survivors, because they are closely interrelated to everything that our patients undergo. So as it mentions, survivorship care, basically what it means is late effects management, surveillance for either recurrent cancers or second cancers. So let's talk a little bit about what are the late effects after treatment for AML. And here I have to put in the caveat that a lot of our survivorship literature right now is from the world of hematopoietic stem cell transplant, because right now that's the only modality of treatment for AML that can potentially cure our patients, and we can see sort of long-term survivors and see what kind of late complications they develop. However, as our treatment, non-transplant treatments change, I think this is going to change as well, and we will start seeing more and more of the literature coming through for these patients who don't ever make it to transplant, but still can have a lot of the late effects and the medical complications of their treatment. So let's start with what all can happen. So these treatments can result in organ dysfunction. It can affect the kidneys, the heart, sometimes the lungs. So we have to be very watchful about those. In our younger patients, in our adolescent, young adult patients, it can cause growth and development problems. It can, the chemotherapies can sometimes, slow down the growth. And even for our middle-aged patients, we know that it can sometimes expedite the aging process, the chemotherapy and the transplant. It can cause infertility, sexual problems. The chemotherapies that people get for AML can sometimes cause secondary cancers. It can cause exacerbation of the ongoing medical problems. So like for my 77-year-old patient, a couple of his admissions were related to his heart, which again, I think what the treatment that I gave him for the leukemia precipitated. And so that's what we have to also be able to diagnose and treat. Infections are a common issue after any kind of chemotherapy because of the immunosuppression. And there's always the risk for, even if somebody's able to attain remission, there's always a risk that the AML could come back. And then it can cause a lot of physical problems like fatigue, pain, sleep issues. And then, as I mentioned, for patient number one, after transplant, chronic GVHD is one of the major complications, and it can be also related to a lot of other post-transplant issues. So nowadays, we realize that it's not just the medical problems, the psychosocial sequelae of AML treatment are very important to recognize and treat appropriately also. And so here I try to divide them into physical sequelae, social sequelae, and psychological sequelae. So physical sequelae include things like fatigue, chronic pain, sexual issues, fertility issues, symptom burden, and disability. The psychological sequelae, there's a higher chance of depression, anxiety in our patients who've been treated, like patient number one. There's a higher perceived stress. There can be adverse coping. There can be cognitive dysfunction, so-called chemo brain. It's actually a physical problem. It's not something that people just imagine. And then there can be role limitations. Somebody who has been in the role of being the primary provider for the family may have to step back because of their AML and their treatment, and now that can create emotional challenges for them. And then there's the social sequela, which includes financial distress, the ability to socially reintegrate back into the society, problems with returning to work, and marital problems, just like our patient number one. So what are some of the factors that influence all these late complications, including the psychosocial effects? So first and foremost is disease and treatment related factors. In that type of acute leukemia, so we didn't talk about, but APL or acute promyelocytic leukemia is something that is considered actually more of a curative. Most patients can get cured from it. So for that, the late effects might look different from the other types of leukemia. Clinical characteristics. So again, if somebody is coming into a diagnosis of leukemia with a lot of other medical problems, that can influence some of the other outcomes that they will have. And then chemotherapy versus versus a bone marrow or stem cell transplant for their treatment can also change the kind of late effects they will have. Then there's the socio-demographic factors and the comorbidities or other medical problems. So age, sex, race, ethnicity, education, income, marital status, insurance, and all these other medical problems can also have an impact on not just the psychosocial outcomes, but sometimes the medical late effects as well. And finally, the psychosocial and work-related factors, such as the amount of social support, psychological comorbidities. So somebody who's already having a depression or an anxiety diagnosis at the time of their AML diagnosis may have a more difficult course with their treatment. Type of work, employer support, rehabilitation services, all of that can affect the other psychosocial sequela as well. So I think I don't need to stress this, but I think you all will realize that the individual risk for late effects is very different for somebody who, as an 8-month-old, was treated and then cured from their AML with an allogeneic transplant versus like my third patient, the 77-year-old, who is, either just got like one cycle of treatment or was able to go into remission and is now on maintenance chemotherapy after attaining remission. So their survivorship would look very different. And that's where the physicians have to be able to recognize that and offer care that is more personalized to each of the patient that they have. So what do we do about these late effects? What I have proposed is that we should have a tiered approach to these late effects. And that would be basically the 3 levels of prevention. So primary prevention here would include health promotion activities, such as encouraging healthy lifestyle for our patients, increasing awareness. So this is a good event where what we are trying to do is increase the awareness about the survivorship related issues and encourage people to seek care appropriately for that. And addressing risk factors. I have a slide later on that I will talk about what kind of risk factors, mostly lifestyle related risk factors. The secondary prevention would include screening, and screening should not be just a one-time thing. It should be periodic. It should be done every so often for our survivors because things change. Their problems can change along the trajectory of their AML treatments. Early intervention can help improve the overall outcomes if we are able to diagnose something and treat it early. That would lead to overall better outcomes. And then management of comorbid or the other medical problems that our patients have would be a part of secondary prevention as well. Tertiary prevention is mostly around rehabilitation or limiting the disability and efforts to improve quality of life and limit mortality. So just to give you some examples, what does screening look like? At least here at our center, especially for our transplant patients, there are specific set guidelines that we try to follow, but we've tried to do this for our non-transplant patients as well, where we try to, I've had patients that have been sort of cured from their AML now with just chemotherapy alone, and I still try to follow this sort of, these steps to be able to take care of her. So it includes annual comprehensive evaluation for a history and physical, includes testing for cholesterol, fasting glucose, because those are risk factors for heart disease, seeing if we need to do an echocardiogram to look at their heart function or an EKG, and this would depend on what kind of chemotherapy they would have gotten as part of their treatment. For certain patients, very infrequently, because we don't use chest radiation for our AML patients, but some of the chemotherapies that we do can be toxic to the heart in the long term. So for some of those patients, we might, and especially for our transplant patients, sometimes we will do a stress test 5 to 10 years following their treatment. We usually encourage annual dermatologic or skin evaluations because skin cancers are common in our transplant patients especially. And then, we try to have screening tools for anxiety, depression, and distress because, again, those are things that eventually will affect physical health if not addressed. In terms of the risk modification, again, as part of the primary prevention, what we would encourage our patients is to avoid smoking, limit alcohol, low-fat diet, encourage physical activity, avoid sun exposure. And then I always tell them you need to go back to your primary care doctor periodically to get things people your age and gender need, whether it's a mammogram or pap smear or colonoscopy. You need to discuss that with your primary care doctor. And then vaccinations are very, very important, especially for our transplant patients who uh, have had their transplants for AML. Management of comorbid conditions is again very important, especially as we start seeing more and more patients who are coming in with already, heart disease or kidney disease or lung disease and so forth. And then psychosocial care, meaning again being able to screen for and treat anxiety, depression, and all of those other things that can help improve the quality of life for the patient. Some of the other treatments for psychosocial concerns, we generally recommend exercise. I have a lot of patients that I send to, we have a good psychologist now that I send for psychotherapy, and some of them have told me it has worked wonders for them. So that is definitely something that we try to do. Especially for the younger patients or ones with some memory related issues from the treatment, we try to do a full neuropsychological evaluation and provide them recommendations to help improve that. And then there are a lot of studies looking at other integrative therapies, yoga, meditation, mindfulness-based exercises, supportive expressive therapies to help improve some of these challenges. We have just finished enrolling for a study where we used digital storytelling videos for our patients who had transplant and their caregivers to be able to help them with coping and emotional challenges post-transplant. So I would be remiss if I didn't highlight COVID-19. These are some of the things that I think need even more emphasis while we are seeing our patients who are AML survivors and how does COVID-19 impact them. I think all of us realize that the pandemic has led to an increased use of the telemedicine. In a way it's good because it opens up access, but we also want to make sure that it doesn't it's not increasing the disparities by letting those patients fall through cracks if they're not comfortable using the telemedicine. One thing that I have always stressed to my patients is that do not delay in-person visits. If you feel you need to be seen, you need to communicate that to your care team, and we will help you get in-person visits. Risk-based survivorship care has become even more important. Again, trying to triage if you're doing well, if you're staying healthy, maybe we can just follow you through video visits versus have you come in person to be able to care for you. Continuing healthy behaviors, including vaccination, COVID vaccination for our AML survivors, especially the transplant patients. Financial impacts of COVID-19 is being realized as an important area because a lot of our patients or their caregivers may have been affected by job losses and so forth. And so that's definitely something that you need to communicate and work with your care team rather than sort of not be able to take care of yourself. And then most important is COVID does not mean social distancing. Physical distancing, yes, but we understand how important it is for our AML survivors to be able to socially interact. And again, HealthTree for AML, I think they have a good platform of bringing people together via using the online methods to be able to encourage communication with each other. As I mentioned, caregivers are now included in the definition for survivors. And so there are studies now that are recognizing that our caregivers for our AML patients undergo a lot of challenges too. These can include physical challenges like fatigue, sleep issues, sexual dysfunction, can include psychological complications, depression, distress, cognitive or memory issues, social challenges such as feeling kind of isolated, lack of social support, role conflict or financial and employment issues. And all of this has led to increasing burden for our caregivers and poor quality of life for them. And hopefully there are studies that are now targeting caregivers as well to help improve their outcomes. So this is just before I end, I wanted to go over some of the barriers in real world. In an ideal world, we would want to be able to deliver individualized survivorship care to all our patients. However, there are a lot of barriers in real world, and these could be at the level of the patient. So there may be lack of awareness. There could be socioeconomic or logistical challenges. A lot of times, especially for our transplant patients, they will move close to the transplant center for transplant and then go back home, and may not have the financial means or the ability to continue to come back and be taken care of at the transplant center. So for them, we need to think of other ways to be able to provide adequate care for our patients. It could be at the level of the provider, and that could be because there's not enough resources or tools to recognize and address the problems for our survivors. A lot of the research is focused on the front end, where we are trying to improve the number of medications, the number of treatments that we have available for treating AML. But I think we need to also think about what are we doing for patients that are able to live longer and better after they've been treated for their AML. There may be lack of interest. A lot of, like I said, providers are probably more interested in the upfront side and not so much about, the survivors. There may be lack of awareness of guidelines. So like I mentioned, for our transplant patient, there are guidelines, but and then there are NCCN guidelines for general cancer survivorship, but there may be lack of awareness. There may be inadequate communication. When a patient is being treated, they may be seeing not just the hematologist, oncologist, but also their primary care doctor or other specialists. And sometimes that communication is not the best. And then there can be challenges at the level of the system, hospital level challenges, which could be lack of reimbursement for some of these survivorship care kind of services, poor care coordination, again, trying to communicate between different providers. There could be competing priorities. Again, the hospitals probably want us to see more patients that have a new diagnosis that we can start on treatment. But I think they need to realize that taking care of our patients who've come through that is as important. There may be, again, lack of resources or specialists who are focused on survivorship care, and inadequate quality assurance. We don't have good benchmarks for the long-term outcomes. All our focus is on the short-term outcomes of survival and getting relapse numbers down. So here, I just wanted to summarize here what's the current state. So the good news is that we have lots of new treatment, including targeted agents for certain mutations that are changing the landscape of how we treat our patients. The good news is that a lot of people are now realizing that quality of life is as important as survival or relapse, and those are being assessed with some of these clinical trials. There is emphasis on individualized treatment, whether it is based on their mutation marker or their functional status prior to treatment, or even during treatment, the minimal residual disease techniques, which is to detect how much amount of leukemia is still there, can help change the treatment profile for some of the patients. And there's definitely improvement in supportive care. We have better antibiotics, we have better preventive care the techniques. And so all of that has led to overall improvement in our AML survivorship, both in terms of quantity and quality. Things that could be done better is our ability to provide evidence-based care. Unfortunately, with the explosion of all these different types of mutations and the medicines targeting those mutations, it's become a little bit challenging for especially our community doctors to be able to provide evidence-based care, to keep up with the up-to-date knowledge. And so that's where the leukemia treatment is now starting to get more and more limited to the tertiary level academic centers, which can impact access to care in the long term for our population. So that's a problem that we need to really think of solutions. We need more studies about late effects, understanding the mechanism behind it so that we can design better interventions to treat them. We need better survivorship care models to be able to provide care for our survivors, whether it is improved use of telemedicine or other ways to make sure that everyone's able to get the care that they need. And finally, continuing to raise awareness about these issues is important to make sure that we are also addressing things at the far end rather than just upfront. And so I would like to leave you with this quote, which is the inspiration for all of us who work in the area of survivorship, because it very much is spot on recognizing the challenges for our survivors. And with that, I will end, and I am happy to take questions.
Thank you so much, Dr. Khera. That was excellent and lots of really great and important information in your presentation today. Again, we'll be sending out slides so you can reference them again on your own to go back and look at all of the great information in them. We can move forward now. We have a good amount of time for some Q&A and discussion. And I'd like to hopefully pose this as to be a little bit more than just a Q&A. I'd love for us all to really connect here and share our experiences. I think Dr. Khera mentioned that survivorship starts at diagnosis. So no matter where you are in your treatment, I'm sure you have really great insights for others to learn from you, and you learn from them in this survivorship journey that you're on. I see a raised hand already here from Ted. Hello, Ted. It's good to see you. I'm glad you had your seatbelt on. You were making me just a tad nervous. But I'll let you go ahead and ask your question or make your comment. I think you're muted.
Sorry, I was on mute. Doctor, my name is Ted Peterson. I have a precious 31-year-old daughter who was diagnosed with AML leukemia. Unfortunately, RUNX1 subtype, treated at Hopkins by Dr. Mark Levis, who, as you know, is very prominent in the field and a really, really good person. She lives in Baltimore with her husband and is dealing with all those psycho issues that you suggested about fertility and such. She had two, I'll just give you a quick background, then I want to ask you a question. My daughter's name is Ida. She's had two transplants. The first one, he thinks she may have gone in MRD, came out MRD. And thank goodness he was able to treat her with azacitidine for about 7 months. They looked at doing a couple of other things and elected to go with a second transplant, which thank goodness has worked 7 months to date. Blood work looks pretty good. So we've been on a long journey here. This weekend, my daughter went out with her husband. It was a hot weekend here in Baltimore, and they went into some honky tonk bar and had a bunch of beer. She's not the kind that gets wasted, as you could term, but she had enough beer that she walked out, tripped on a uneven sidewalk, cut her knee open, was treated at a Hopkins emergency room place. She called Dr. Levis immediately, and he said, your immune system should be good enough to bounce back from this. So my question is, you mentioned alcohol. I'd like to know, why not, and what does it do from your perspective? Not that this kid's a drunk. I'm just suggesting she's in the middle of, everybody in her world drinking at every event they go to. And the second is, could her balance and strength have been off by this long-term treatment of 23 months of being treated for AML? Thank you.
Yeah. So first of all, I'm glad to hear that she's doing better. I do endorse that she's had a rough and long journey, but hopefully this is, she's been able to get cured from it, hopefully, and she will do well. Alcohol, I would say, we say to limit alcohol. I definitely don't want my patients who are still on immunosuppressive treatment to continue to do any alcohol, because for one, if their liver numbers start to go off, then we wouldn't know whether it's from alcohol or medications or graft versus host disease. And so to try and not get into that confusing situation, we try to have them avoid alcohol, especially when they are on immunosuppressive medication, some of the antibiotics that can interact and so forth. Once they're done with all of that, I would say, like, if you have a celebration and you want to have a glass of wine, totally fine. But it's just that we don't want people to be doing that in a more routine fashion, because again, the one worry that we have is the risk for second cancers. And so, alcohol overall can increase certain risks like that, especially if it's being done in a lot of or huger volumes. But again, I've had patients who've asked me, it's my husband's birthday or whatever. They've been off immunosuppression, they've been off all their meds. And I'm like, okay, fine. Just don't overdo it. But it would be fine to do a little bit. The
So,
second
I
question,
could, yeah, go ahead. Sorry.
no, go ahead.
No, I did tell her that if she's going to drink, she has to pee in the backyard where she can fall in the grass.
Yeah. And
Sorry,
not
go ahead.
overdo it. Just maybe a
Not
little
overdo
amount,
it.
not
Yeah.
overdo
And
it. Yes.
that's my real point. But then I wondered if
Yeah.
maybe her body was reacting to this. So sorry to interrupt.
Yeah, definitely. I mean, her body is beat up from all the chemotherapy, the 2 transplants, and it will take time for it to get back to, close to her baseline. And there are studies that suggest most people, if they have sort of a non-complicated course, will get back to about 80% of their baseline by a year or so after transplant. And but the thing is, now she's had 2 transplants, so she's definitely, those markers are going to be even longer in terms of her ability to get back to baseline quality of life type things. So
Thank you.
sure.
Great. I see a raised hand from Maureen, so I'll let you go ahead.
Hi, just to follow up on his question and his daughter, I was actually AML 2019 of March. I relapsed April of 2019 and then had the stem cell transplant July 2019. So I just recently turned 3. Originally, my doctor would allow me to have a beer here and there. But my counts kept going up and down. So then I wasn't having any, like it was a month or 2 later and I haven't had a beer. And when I did have a beer, I'd sip on a beer for like 3 hours. I just like the taste of it. But anyway, so my counts were going up and down. So then they sent me to a liver specialist. So I haven't had anything since September of 2021. No alcohol. So I would just tell her to be very careful, just because, especially having the second transplant, to have those worries of your counts and something else going on. Even though I really, really want to have a beer, I would just be super careful. Or I would tell her that.
Thank you.
To watch.
Thank you.
Just because, I mean, you worry and have anxiety. I mean, at least I do, as it is, of worrying about relapse, because my MRD was 0. And I relapsed.
Mhm.
So when I got my results for the MRD after my transplant, I wasn't too excited because I'm like, well, you've told me that before. I'm grateful that it's 0, but it's not comforting. So is there, that was my question, besides about the alcohol, is just wondering, how accurate is MRD, and, what are the chances of relapsing?
Right. I think you bring up a question that could take a whole day of presentations, especially with all the new things that we have going on in that MRD realm now. So MRD is what we call minimal residual disease. There is Dr. Chris Hourigan from, I think he's at the Hopkins or NIH, and he actually calls it measurable residual disease, meaning we have to be able to have tests that can pick up as low as 1 in 100,000, 1 in a million cells, and see how that can predict the leukemia from relapsing. So I'm not sure what kind of MRD study you had, Maureen, but again, if the sensitivity of that was low, then that may not be very much predictive of a longer term outcome. However, there are definitely now tests that we have that can pick up that low level of, even like 1 in 100,000 to 1 in a million cells. And those have been shown to be very, very sensitive in order to be able to predict relapse. That being said, it's not 100% still. And so even though when we look at the studies, we try to collate the data, you may not fit that data, and you could be outside that range. And that's why, but what we would suggest is basically following you closely with very, very sensitive MRD test results. Now, on the other side, that does create some issues. So I had a patient who continued, in fact, he's just moved to North Carolina for a job, and he's continued to have this very, very low level. He has an NPM1 mutation, and so we've continued to monitor that, and he's had like 0.03, 0.05, like that. And so what do we do with that? I mean, after discussing this a lot with him, I told him that, I feel like he's doing great otherwise. He's back to his job. He's, functioning at his normal level. And so to try and have him feel anxious about it, I don't know. I mean, we've had discussions where we've talked about how his risk for relapse probably will be slightly high than if he was 0. But is this very, very low number enough that I would react on it? I've already given him some gentle chemotherapy after transplant to try and eradicate it, but it's just stuck there. And so we've decided to just follow him very, very closely. And if at any point we feel like it's going from 0.03, 0.05 to 0.1 now, then we would act at that time. Because otherwise, you put somebody in that situation where you don't really understand very well how these tests would predict for long-term outcomes. That being said, again, this is changing every day. It's evolving. We are getting newer techniques. And so hopefully we will be able to do a much better job at predicting who will relapse and who will not.
Thank you.
That's really great that we're having this MRD conversation. I think this is really the first time in any of our programming we've really touched on MRD, and something I really want to incorporate more of, as it's such an important, complex, and ever-changing topic. So maybe we can get a speaker on in the near future to do an entire presentation on MRD. So thank you for providing that. Okay, Ted, I'll let you go ahead.
Okay, thanks. Just as a follow-up question, Doctor, this is Ted Peterson again with regard to my daughter. So have you ever had a patient or know of a patient that's been through that much chemo, not that you know exactly about my daughter, who's ever had a menstrual cycle again, or has gained any fertility?
I would say not after 2 transplants, but I've had a male patient who was able to, they were able to have a baby 2 years after his transplant. A female patient that I had, she was 4 years out, and she did get pregnant, but then she lost the baby. So, I mean, it's not completely impossible. However, the chances, especially the more amount of treatment you've gotten, does decrease the overall chances of getting pregnant and being able to have a baby, really drive them down.
It's easier for me to ask the question. My daughter, obviously, that's why I'm asking. Are people that have with young women who have had this, anyone that you're aware of, is there not maybe a person, but just generally in the marketplace, is anyone able to carry a child through purchased egg, if you will, or whatever you call it, or a donated egg and the husband's sperm? Could the cancer survivor after a certain amount of time actually carry the child?
Yeah. There are case series that have published successful pregnancies, both with donated eggs or even sometimes harvested before treatment. So one of the largest case series is from Fred Hutch Cancer Center. Like I said, the rates are pretty low, but there are definitely successful pregnancies being able to carry it successful to term.
Your point, so many cancer victims, if you will, our patients are, over childbearing age anyway, right? So the numbers may be low, but there may be a low number trying it. I'm not trying to be wishful thinking here. I'd like you, I'm a matter of fact person, but then it's easier for me to ask as a father than as the
Sure.
person that's dealing with it
Sure.
psychologically. But I was
Yeah.
curious about that. Thank you very much,
Yeah.
Doctor. Very great
Sure.
presentation.
Thank you. We do try to encourage, if at all, patients can get some sort of fertility preservation things done before they start their treatment for leukemia. But more often than not, the main barrier there is either they have a very aggressive leukemia that we won't be able to wait for them to get, say their eggs harvested or sperms collected. And I think the second main barrier is the logistical piece, because a lot of times insurances will not cover those procedures, and so it falls down on the patient to be able to do this from out of pocket, and that sometimes can be hard. So, but there's definitely push in the field to try and do the better job of doing this for our younger patients.
Not to be a smarty pants, but easier for the guy than the girl. Right. I mean, we couldn't wait. We were 3 weeks into it, and Ida exhibited with a long menstrual cycle, a lot of bleeding. That's how we determined the AML in the first place. So we were boxed against the wall.
There's complications that you worry about in doing those procedures that can be in that decision as well. So yeah.
Thank you again. Excellent job. You're very.
Thank you.
Okay, we have about 10 more minutes. If anybody else wants to raise their hand or put something in the chat, while we wait on that, I have a few things that I've observed from our community and been asked that might be helpful to discuss now until I see anything pop up. But what I see a lot is that patients who have gotten through their treatment, gotten through their transplant, kind of feel a bit cut off in a sense, in that they're still needing care in all of these other supportive ways, but their AML team is not necessarily the ones to provide that, and they feel like they're kind of alone in a sense. And I'm curious if that's something that you see or have seen, and what your thoughts on what patients can do in order to seek out that care in a lot of those complex ways. There's a lot of different care that needs to be happening. So I'm just curious your thoughts on that.
Yeah, I think, Katie, you bring up a very good point. We do see that in our patients is this feeling of social isolation, or lack of or feeling that there is lack of social support. And obviously the pandemic has made it even worse, where they are trying to limit themselves to not meeting people and all of that, which is where I suggested physical distancing, but no social distancing, especially now with all these online platforms that we have. So I would say that, again, these are things that researchers are looking at. This study that I told you about, the digital storytelling video studies, what we did was we first held a workshop where we invited patients who had their transplant and their caregivers, and we had them sit around. It was a 3-day workshop. They sat around, they talked about, what they were going through. And then we asked them to basically develop their own stories and create videos with them. It was done with the California Center for Digital Storytelling. And so they were really good at making some nice videos. So, and then we used those videos for our future patients to show them and make them feel like they're not the only ones going through this. This is kind of what other patients have gone through. And so I can tell you from the workshop, the feedback that we got was amazing. People just loved sitting around the table and talking about their concerns and feeling like they were not alone in this fight. There were other people who had sort of gone through the same things. Again, things could be different for somebody who is a young reproductive age group person versus an older person. Their challenges are different, but bringing them together around the table, I think, made them feel connected, and they really appreciated that. And then we are still analyzing the data that we've collected, but in general, just the preliminary look at the data does suggest that those videos are actually helpful for even the future patients to feel like they're not alone in this, and that they have other people who've gone through the same and have been able to do. And then we do try to encourage them to talk to their care team about that. Again, that can be hard sometimes, especially if they're away from their transplant center and they're seeing a regular hematologist who may not really understand those kind of problems very well. But hopefully raising awareness, having societies or associations like you are doing a great job of bringing a community of people together and make them feel like they have other people to look at during their journey for AML.
Great. Yeah, and I think it's interesting you bring that up. We at HealthTree are, I guess on Friday, we just launched a video journaling feature that's now on our website. So it's pretty cool that what you're saying aligns with kind of the things we've been thinking as well, to where patients and caregivers can journal in a sense via audio or video and share that with people. And so hopefully that brings some comfort and assistance to others as we build that. So yeah. Okay, I don't see anything else. I'll give it maybe a few more seconds. Anybody else?
I think Kerith has her hand raised.
Oh, hi, Kerith. I missed your hand.
Hi, how are you?
Good.
This is less of a question, more of a comment, but there's this book that I love, and it's by Suleika Jawad, and I recommend it for people, and it's called Between Two Kingdoms, because it talks about, you've come from being sick, but you're not exactly in the land of the being well, because you have all these physical symptoms that still, and then also the psychological as well. And unfortunately, she relapsed 10 years after her transplant. But the book explores a lot of that, sort of being between those two worlds. And I think that this is something that we at HealthTree can work on as well. But I'd like to pose the question to you. And I think, you were asking some of these questions in your presentation of like, maybe there's an opportunity for the care centers or the hospitals to have these types of resources available of possible support groups. And I know it's difficult, obviously, with the pandemic still happening, but specifically for survivorship. And I wonder if, the social workers at the hospitals are thinking about that and doing something about that.
Yeah, absolutely. So we have a very nicely run support group for our adolescent young adult patients with cancer. It's not limited to one type of cancer, but it basically invites anyone in that age group to come and share. Right now, it's being done as like a Zoom call rather than in person, but it used to be in person before the pandemic. And I can tell you, the social worker, Melody Griffith, who runs it, she tells me that they really are able to make a difference. The one thing that sometimes can be a challenge, we try to do something for caregivers as a support group, is they don't have the time sometimes. I mean, they're so busy taking care of their patient. And so being able to take those 30 minutes or 1 hour out of their very busy time sometimes can be a challenge. But that being said, when they are able to attend it, they really do appreciate what how helpful it is to them. So we definitely, as centers, need to work better on creating those kind of opportunities for people who are interested.
Yeah, and I think we here at HealthTree, because I work with Katie, can maybe perhaps have something that's more geared toward survivorship, because there is, I think, a gap there that needs to be filled for sure.
Yeah.
Thank you very much.
Sure.
Okay, I guess we'll wrap up now. We're staying right on schedule. So I usually announce our next event for the next month, but I'm still working on dates for August and September. So I hope you'll check back on our website at healthtree.org/AML/community/events in the next few weeks. I should have some registration pages posted then, but you'll receive an email anyway whenever I do have registration links available for our future events. Once again, thank you to our HealthTree community for AML event sponsors, Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. And thank you for helping us build a strong HealthTree community for AML. I appreciate you all for being here. I hope you have a great rest of your day. You stay cool, and I hope to see each of you again soon.
Bye.
Bye.